Alrighty, so we're going to go ahead and start with a review on your balanced body torso weighting. And I want to talk about patient selection, the weighting and assessment, just kind of refresh stuff in your brains and what you learned, and then the new vest ordering process that we have with our new inpatient vest. So who's the right patient? I think this tends to be a little bit, I think this is kind of where we hang ourselves up a bit. And so I'm just going to throw a couple of patients up here, and if for those of you on webcam or some of you can throw in the chat box if you think this is somebody that you might try balanced body torso weighting on. So these are old patients of mine that I saw when I had an outpatient clinic. And so, okay, can everybody see the video? All right. Is there any audio coming through? Okay, no audio now. Okay, good. So just watch her walk. So this is a lady with MS. So obviously she's an independent ambulator, correct? There's no problems, but she's very slow. So is this someone you think you might try the vest on? Can I see some nods? No? Yes? What do you guys think? Okay, so I see some nods. And, you know, now we're in this lecture, and of course you're thinking, well, Andrea's going to put all these people up here and they're all going to be yeses. Well, you're probably right. But what I want you to do is kind of think outside the box. This is somebody that doesn't initially strike you as, oh my gosh, she has really bad balance. But perhaps if she felt more stable, she might walk faster. Because remember, gait velocity is one of the things that we're using to actually objectively evaluate whether or not a vest is helping someone. So although she doesn't immediately strike you as someone who has some serious ataxia or coordination problems, the slowness of her gait makes me think, I might give this a try. It may not work, but the point is that I would like us to not rule people out right out of the gates. And you'll see as we move through this that Cindy and I have talked, and I think we've come up with a little bit more of a usable process for us in our environment where we'll be able to get a little more access. So let's look at this one here. This is a patient who is a stroke patient. And so two things. This is one of my favorite videos that I took of this woman. And so she obviously is a high-functioning stroke, but still has what I call pretty funky gait. That's a clinical term. So when this woman, you see how stiff her right leg is when she's walking? Now watch this. I put her on foam. How does that happen? This is just the most intriguing thing to me from a motor control perspective. So here's somebody who obviously has great reactive responses as far as her postural control goes. She's stumbling all over the place. She falls occasionally, but not very often. But if you look at her gait here, look at how her right lower extremity, how stiff it is. And it looks like she doesn't have, you know, I immediately suspect extensor tone, just too much extensor spasticity. I'm thinking, oh, let's give her some baclofen. Let's see what she needs to do there. And then she goes on the foam and she shows me that she totally has the motor program to have normal gait and flexion. So this is a little beyond really why this is happening. From a motor control perspective, I don't personally have all the answers. I don't know if anybody does. But what that woman just showed us from a hard surface to a very gushy surface over here is she actually can unlock and has a motor program to walk that way. So maybe at certain speeds, she doesn't feel as confident in her balance. Maybe trying a vest on her might help her. I don't know. But what I'm trying to explain to you guys is this is somebody that she obviously has potential that she's not using regularly. It's not automated on a firm surface. So perhaps if we provide her some more internal stability and some more proprioceptive input, some sensory input, maybe that's going to make her be able to feel like she can bend more. Again, I don't know. But let's not rule people out before we try it. Here's another example. So this is a person with CP. She's a 45-year-old woman with CP. So yes, we're in geriatrics, but CPs do get old, and we do see them in the geriatric world as well, because, right, even though they were born with it, it doesn't go away, and they eventually get old. So this woman obviously has a very, very involved gait. There's a lot of things going on here, long-term contractures, in the trunk, in the hips. There's a significant amount of spasticity. So is this someone I would try a vest on? I mean, go ahead. You guys can say yes, no. Okay, Bo's thinking, yeah, I'm gonna give it a go. Because I mean, really, what is it gonna hurt? It's not gonna hurt her. I mean, that's the beauty of this intervention. To me, this is just another technique that we have to see if we can improve something. In someone like her, I have to be totally upfront with you. I'd probably try it, but she has so many contractures and she has so many biomechanical limitations in addition to central nervous system problems that I don't know if, you know, I'm kind of personally, I'm thinking I'll give it a try, but I don't think this one's going to work. And, you know, I don't have a crystal ball. So, and as we do more of these and as we get better at it, you know, I don't know how you guys are, but within 15 minutes, I can pretty much get a pretty good idea, 10 to 15 minutes, of whether this is going to work or not. I mean, for those of you that are using it, would you agree? This doesn't have to be a whole 45-minute time commitment for you. It's part of your regular treatment. Put the vest on, throw the weights on, see if you've improved the rotations, some of the perturbations, and you're like, oh, I'm on to something. Something's a little better. And then you can continue to work on it and dial it in. So again, I don't want you guys to approach this thinking that, oh, wow, you know, oh, no, not this one. We can't do it on this one. No, this is just way too involved, because we don't know. And let's do one final one. So this is, again, a patient with MS. So obviously independent ambulator, correct? Lacks adequate knee flexion bilaterally, extremely slow velocity. I mean, I don't really know what her velocity is at this point, but I peg her somewhere around 0.2 meters per second. You almost need like a time-lapse photography camera to kind of see her moving. The point being that I have to ask myself, is she that tenuous because she's afraid of falling? Is she that tenuous because she is not confident in her balance? Again, I put a vest on her, I do some quick assessment, add some weights. I can objectively measure to just see if that ambulatory velocity increases. Maybe we're going to see some gait deviations improve, maybe not. But if we improve our ambulatory velocity, as we all know, gait velocity is a huge prognostic indicator of functional outcome and just general prognosis down the line for hospitalization, risk of falls, and then ultimately mortality. So if we can get people walking faster because we provide them more stability, I just don't want us to be making the take-home message from these few patients is let's not decide who is or who is not appropriate until we've tried it. And we'll address the logistics of that in our environment. Okay, so let's go ahead to some weighting. So Cindy put together this really nice video. I'm going to run audio on it. And give me a thumbs up if you can hear the audio. If you can't, then give me a thumbs down. Okay, so let me start it.
Let's start the perturbation testing. So I'm going to give her some nudges. And that's fine. And I want you to grade the nudge. Okay? What happens with her? Ready? Don't let me mediate. No, the students. Okay, ready? Right. You just try to stay upright. You be strong. Okay? Ready? So that was an anterior. What grade would that be?
All right. So now, correct? So what do you guys think that grade was? Put your fingers up for those of you that I see webcams on. 1, 2, a 3, or a 4 on that anterior nudge. Okay, so Bo's saying 3. Anybody agree, disagree? Anybody want to say that was a 2? Come on, you guys. I'm going to call on you. You can type it into the box. For those of you that saw it, some people can type into the box. Who says that was, who agrees that was a 3? Does somebody think it was a 2? Eric thinks it was a 3 as well. All right. So why doesn't some of you jot this down on a piece of paper and call that a 3? Okay. So that was a posterior. That was a posterior. What are you guys going to score that? Okay, both saying a 4. Eric's saying a 4. You guys are all saying a 4 that are on the webcam. Okay, Christian said a 2 for the previous one. And I think I'm not the end all on this, okay? I kind of would have called the anterior perturbation a 2, and I definitely would have called the posterior perturbation a 4. But again, I am not the ultimate authority, so I'm not going to argue with any one of you, but I think that because she didn't really totally lose her balance or even take a step, I kind of would have put that in the 2 category. But on the last one, I think everybody would agree that was a 4. So let's move on.
Okay, face forward a little bit.
Synapses.
Together, making sure their feet are together. Okay, don't let me leave you. What grade was that?
Okay. Grade? What do you got? Both saying a 2. Come on, Jill. What do you guys say? Eric's saying a 2. Jill, what do you guys think? Melissa, you guys over there, what do you guys think? 2? Okay. Everybody's saying 2. Okay, I think we're all in agreement that was a 2. Good job. Good job. Everybody agree? Okay, somebody else. I don't know who's CD34886 said a 2. Excellent. Good. So I think we're all in agreement on that one.
What grade was that meeting?
Whoa. Okay, let me see the scores, guys. Definitely a 4, right? I mean, serious loss of balance. Okay, everybody's in agreement there. Great. Quattro from Christian. Nicely done. Okay, good. So everybody's in agreement there.
This is an anterior again. So feet all the way together. Don't let me leave you.
All right, so we had an anterior. Everybody would score that at what? Yeah, the anterior was like, okay, the posterior was a 4, for those of you at Clayton. The anterior nudge was a 1, right? Everybody agrees with that? Okay, we lost Durham again. So anterior was a 1, posterior 4, loss of balance. Everybody agrees there. Okay, I'm going to run it.
What grade was that be?
Everybody agrees that's 4. It's a 4.
Feet together. That was to the left. That was to the right. What grade is that?
All right, so left was a Pradeep, I said 4 for the last one. So to the left, Pradeep, what do you think that one was to the left, lower left? What was the lower left? The one we just saw. Everybody agrees on it. Okay, and then the lower right, that was a 4 because she's losing her balance, correct? Okay. So I think everybody's on to this. I don't think that we're that off on the perturbations. So now let's look at the rotations. And the other thing I want to point out is you see that even Cindy, when she's doing this, she always has to go back, circle back around to the foot placement. Because, you know, people start moving their feet apart. So remember, you always have to kind of regroup and say, okay, feet together, after each one of those perturbations. So don't forget to do that.
All right, now, face me. I'm going to try to turn her that way, like this. You're going to resist that, but put your feet together all the way. see my hand? I'm tapping right here. My other hand's on the anterior shoulder. Don't let me turn you like that, okay? Pull as hard as you can. There you go. Pull. And I'm going to give you that. It's a 1. The firing isn't quite as strong as I'd like it. Let's try this side now. Don't let me turn you. Pull right here. Pull as hard as you can. And notice her foot came out. What grade would that be?
Okay. Now, 1 foot came out when she rotated her. The right rotation, 1 foot came out. What's that score? Three? Everybody agrees? 3, right? 2 feet would be a 4. 1 foot is a 3, and just a lot of trunk movement, and that would be a 2. And then she gave a 1 to the other rotation because it wasn't quite firing strong enough. Okay, because remember, you could be a 0 if you're normal. No, both feet did not move, and it was hard to see on the video there, Christian. It was only 1 foot, but good point. So that's our cutoff point. If both feet would have moved, it would have been a 4.
Okay, now we're going to do the lower back. Are your heels touching? Okay, feel right here. Don't let me turn. You're going to turn this leg. Turn to your right. Pull. And that's nice and strong. And pull to your left. Pull. And you see, but her feet didn't move, but I can pull her quite a bit. So what grade would that be?
Okay, feet did not move. Moved quite a bit to the right. So what are we scoring now? 2. Does everybody understand why it's 2? 2 is trunk moves a lot. 3 is 1 foot moves. 4 is both feet would move with the rotation. Okay. All right, I see that, Pradeep. Thank you. Thanks for your response. Okay, so that's just kind of a quick review of the weighting. Now I'm going to let the video run, and you can see where she puts her weights. Okay. And then, and Pradeep, yeah, I know with the video, they didn't video the feet real well. Pradeep said he thought her right foot moved, and if it would have moved, it would have been a 3. You're right, but it didn't in this case. But we just have to take Cindy's word for it. But 2, 3. So based on that, let's go ahead and look where she weighted. And I think you all agree that everybody understands that we weight the rotations first, right? So her right rotations were the worst. So where do you guys think we're going to put? Just show me, those of you on webcam, where you'd put it. And Lisa can't see you, but can hear you. Okay. Thanks, Jill. So what we would like to do is let's visually, those of you that are on webcam, show me where you think you might put your first weight. And some of you perhaps that aren't on webcam, why don't you go ahead and type in and let me know where you think you might put the first weight on her. Let's assume it's a half pounder. Okay, so Bo's saying left upper trap because it was the right rotation that was the weakest of all of them, right? Granted, she has pretty significant perturbations, 4s, losses of balance, but remember, we always do rotation first because rotation can actually fix a lot of the problems. Okay, so I'm going to go ahead and run the video. You're waiting.
So we fitted Marilyn with the balance work, and this is the LSO. So we fit the inside to her, and then I just adjusted the side here and the top here. And now I'm ready to put the weights in. So remember, we're always going to correct the worst rotation first. So you're going to turn here. And the worst rotation was a 3 here because her right foot came outwards. She's got the LSO on. Let's see what happens with just the LSO if it corrected her rotation. Okay, pull this way. Don't let me turn you. Pull. No, it didn't correct the rotation. So we need to put a weight in to control the rotation. And you just open this like so. You're going to drop your weight in along her Here's her spine, and I'm just going to come in along on the inside of her scapula here, and I'm going to close this up. Put your feet back together, and turn to your left as hard as you can. And she's stronger, her foot isn't moving. Let's go down. Now we're going to go back, and we're going to check the rotation at the lower pelvis, which was also a 2 at the time. So let me turn you this way. You ready? Pull. Still there. She can't control that. So we're going to slide in the way. Take your feet apart now. Pick down between L2 and L4 along the spine. Her spine's right here. I got the weight right here. Okay, put your feet together. Don't let it turn you. Turn to your left. Ready, go. And she's stronger. So now we go back and test the other rotation. Turn this way. Strong. This way. Strong. This way. Strong. This way. Turn. Okay, now face her. So her other problems were loss of balance posterior. So let's see what happened with posterior, and the other one was lateral to the right. So I'm going to test those. And she's still falling laterally to the right at the upper trunk. So falling laterally to the right at the lower trunk. And keep feet together. And she actually had the stepping strategy instead of a fall. So that would change to a number of what? So we have to control the lateral loss of balance and the posterior loss of balance. So we're going to come in here, and we're going to put a weight laterally on the left-hand side to control the right loss of balance and posterior and see where we're at. Wait, I'm going to leave that off because I'm probably going to add another weight. Okay, put your feet together. Okay, let's see where we're at. So that's your lateral loss now. Did we control it? What number would that be? And here's our posterior one. So you can see, actually, I don't think we really need to add anymore. Maybe let me just check it really quick. So here's lateral to the right, left, right, left. You still got a little bit to the left and a little bit to the right and a little bit to the left up here. I'm going to come in center and see if I can control that. Just right center, right above her navel. Here's your navel. Here's your navel. There. What? Is that it? Yeah, that's low. Okay, we'll go a little bit higher. Let's see what we got left, and then just kind of zip this up. Oops, sorry. Told you off balance there. Okay. Don't let me move you. Put your feet together. Now it's brisk. What number is that? Oh, okay. So I don't like that. That's not bad. That's pretty good. But I didn't like that yet. So you want to stop? Let's stop. If her back is starting to bother her.
All right, can everybody hear me again? All right, so as you can see, I think that that was a really well done video by Cindy, and I think that's real helpful to kind of reground us. All of you that are on webcam and those of you that have been, okay, Bo's question was, what weights is she adding? There were half-pound weights at that point. They were all halves. She probably would have dialed in more with some quarter-pound weights, but the patient's back started hurting and couldn't do it. So let's, I think everybody got the weighting down. Here's some other really nice examples that we have in on just kind of general pearls that were somewhat in the original, depending on when you guys took the class from me. Some of you may have this in the handouts. Those of you that took it earlier, like the Durham crowd and Clayton crowd, she didn't have these yet. So you can see that that's just your clinical pearl there, that whenever we have weight loss, where your hand was on the back, where you rotated the person, that's always your clue as to where you're going to put the weight. And usually this placement right in here, I've found personally as well, works the best. But also keep in mind that, you know, the higher you go, and even if you angle a little bit over that trap, it seems to make a difference. Remember, you start crossing midline too much, then you become in that no man's land. So for those of you that have done quite a bit of these, I think you will all agree that slight movements of the weight, even the slightest amount, can make a difference. And so that becomes real important. And then once you actually have a vest for a patient, drawing onto the vest with that colored marker helps as well. So just because it's not working, don't give up hope. Just tweak it just a little bit, and then that might help. And then again, on the lumbar area, we want to make sure.
You probably can hear me better now. It wasn't all the way plugged in. The lumbar area, again, just lateral on the paraspinals, wherever your hand was. All right. And then what you're going to find is that in the population that we deal with, Cindy's done a really large study in an assisted living, and there's some data coming back from it. And they had really great results there, and eventually this is going to be published. But what she found is that this posterior weighting, which usually fixes the majority of the perturbations and the rotational weaknesses, does then contribute to a posterior loss of balance, which makes sense because now we've added some additional weight. So sometimes you have to counterbalance by weighting anteriorly just a little bit. So keep that in mind, that we're finding that in this patient population that can be a problem. So although it often corrects anterior loss and it can change your lateral loss, what we're finding in the elderly is that it actually starts contributing to some additional posterior losses of balance. So if you have posterior loss, here's another one, is if it's a bilateral loss, you could just put that baby right in the middle, or you can, if it's just for trunk movement, drop it down a little lower and you can have it here. So these are things that she's come up with. Again, these are not staunch and evidence-based kind of decision-making that this is where it goes. What you want to know is this is her clinical expertise, and because she's done so much of it, it doesn't mean you can't veer from that. I think the beauty with this intervention is you can put it wherever you want. And again, it's not going to hurt the patient, right? So you can always take it off and move it somewhere else. So for lateral losses, this is a nice place to put it, okay? Or if we have a loss to the left, then you put it on the right. I think these are all pretty self-explanatory. So hold on, I'm hearing somebody here. Who is it that I am hearing? Somebody is not muted. Hold on one second. So on the rotational weighting, this posterior loss of balance has been occurring, and so consider this anterior weighting. And I'm personally happy when I get the majority of our patients down to a 1, or sometimes even a 2. As you get better at it, like Cindy is, she likes getting everybody to a 0, but I think that takes a lot of real fine-tuning. In our case, I think if we can drop people down to 1s, that's pretty good. All right, so here's this new process. So one thing that we're not seeing is we're really not seeing those of you that have been trained using it a whole lot. I know Clayton's had a pretty good volume, Durham, you know, Bo, you've used it quite a bit, and then Christian, you've talked and you've reported that you have been trying it. But I think that, you know, I thought a lot about logistically, why is it that we're struggling with this so much? And so, you know, we can talk about some of those obstacles, and then we'll come back to this slide. So what are they? I mean, do we not have enough vests? I mean, if we have one assessment vest, and then you try it and you're like, okay, well, it looks pretty good, so now what do I do? Right? Because you don't want to take the assessment vest and put it on that patient and have them use it, whether that be a resident or an outpatient. I mean, are you guys agreeing with me that, as we've had these conversations? So that's why we worked and finally came up with this inpatient vest, which we'll talk about. I sent you out the order form for it. There's different sizes. It's pretty generic. It's a lower quality vest, but it costs a lot less. And I think that it would really behoove us to perhaps have one or two of these vests, these additional inpatient vests, as part of the rehab fleet, for lack of a better word, that you would have these extra vests so that when you did the assessment and you're like, I kind of like how this looks on this resident, but I'd like them to wear it for a while, this would be a way to do that in a more inexpensive fashion. So now the weights are purchased separately. And so you'd have an assessment kit, and then you'd have some of these inpatient vests, these temporary things, floating around that you could use, launder, and then reuse them. But then when you finally decide that this indeed has decreased the patient's fall risk, it's making a big enough difference, then you would go to your administrator and say, look, we're diminishing this patient's fall risk. We need to get one of these vests. Here it is. We order it through our process, which we'll review in just a second, and then now the patient has it. So I would like to see all of you starting to use that we have available. So we talked about predetermining who's a candidate before we even tried the weighting. I think hopefully kind of sent that message with the videos in the beginning that I think we just need to try it on everybody, and then we'll go to how I think we can get there. And what determines if the vest is effective? Well, as you know, through the education that I provided for all of you, I would expect that we use some objective measures. I don't really feel comfortable saying to one of the operators that, we need to buy a vest for Mrs. Jones because she feels so much better with it on. I mean, to me, that's not an objective measure of diminishing fall risk. That's not a good return on investment for us. Now, if that's an outpatient who wants to pay for that out of pocket, and they're like, I just feel better with it on, and let's say you didn't see a huge improvement in the objective measures, if that's what they want to do, that's up to them. It's their dime. But when it's our dime, I think that we need to be very objective and evidence-based on these are the things that change when the patient wore the vest. And I think that through the education process, hopefully I drove that home, and I would expect that they improved at least one or two, at least two balance measures, and hopefully even gait velocity. Maybe it's posture when they're sitting, maybe it's their ability to swallow. If you can be objective about that, then I think you have something to go to your administrator with and say, we really need to do this for this patient, because we're paying for that. And that's all I'm saying. And then for those of you that are seeing the outpatients, again, if the outpatient is all about having this thing and you really didn't see all those improvements, there's no reason not to say, okay, on my clinical judgment, based on what I've seen, I can't say this is really making an objective difference, but if you feel qualitatively and subjectively that this is making a difference for you, then go ahead and order it for them. And so, how do we justify it? I think that I just kind of explained that. And what do we document? We'll talk about that in just a second. So I know, and now that, I've been with the company a while, I see that I think this might be part of the problem. We have our PTs and our OTs who are funneling through eval after eval after eval, and then they're moving the plan of care onto an assistant. And then you're checking back every once in a while. And it's easy to lose track, I think, of the patient. And a lot of us don't have time in the initial eval segment when you first saw that patient to actually do this process. And then you have to, you're not doing the schedule, you're not always keeping the patient on your schedule. Program managers are putting the patients on assistance schedules. And so this is why I personally, and you guys can, at the end we'll open this up, you can disagree with me, but I was thinking that if we have plenty of assistants that have been through these workshops, and they do a very good job at waiting and at doing the entire process as well, but assistants can't actually assess. So, but assistants can treat, and assistants are allowed within their scope of practice to make some decisions and work within that neuro-re-ed treatment. That's really what this target sensory weighting is, balanced body torso weighting. So there's no reason why an assistant during a treatment couldn't throw the vest on them, try some weights based on some of their quick testing, and then if they see a difference, then they go back to the supervising therapist and say, can you please do a complete assessment? I think that this is going to make a difference. And that's how we would circle it back around. Because I think what was happening is the actual treating therapist didn't have the ability in the initial eval to do this. You just don't have the time. There's so many other things to do. And then the patient just gets whisked off onto somebody's schedule. So with this new process, I'm thinking that if we allow and empower the assistants to use the knowledge that they learn, these are the ones that got the training, and then they play around with it and they're like, I think, and they're objective and they see the differences. I don't see any harm in them doing that as part of a neuro-re-ed treatment, just like any other kind of thing that you would add or try on a patient, whether that be TheraBand or resistance or so do you guys following me? Do you guys agree that this would be within the scope of practice? Okay, so I don't think we're doing something that is not within the scope of their practice, but then it has to circle back around and a complete assessment and evaluation has to be done by the supervising therapist. And then I'm hoping that we're not going to have so many patients just fly off and go under the radar that we're not noticing because you as the treating therapist were too busy. And so I do expect that change be reported to the supervising therapist, and they could say, I tried the vest on him, didn't seem to make a difference, made him worse, whatever, but maybe I wasn't doing it right. So that's where that communication has to happen between the therapists, but it's okay for the assistants to go ahead. So the message I want you to deliver, all of you on the call right now, is that if you have assistants that were trained formally in a balanced body torso weighting workshop, it's okay to allow them to go ahead, be free, try the weighting, and then circle back around if they're feeling that there's a difference. They certainly have the intellectual ability to do that. And then the primary OT or PT would do the formal assessment. All right. So let's look at what kind of documentation examples. I don't know if some of you were struggling with what to document. I put a couple of buzzwords in here that are phrases that I think might help on what you might document. So patient's balance was facilitated with targeted sensory weighting. That's just a nice lead-in line. You could talk a little bit more about what you did. Balance activities with augmented sensory input through strategic sensory weighting. That's actually the language that she's starting to use, and I think that it's more appropriate instead of balanced body torso weighting. It's just augmented, it's sensory, targeted sensory weighting. That's what she's actually trying to change the product kind of name to. So I think as we incorporate that into our language, that's going to make it sound more of what it really is. Patient performed reactive and anticipatory balance activities with augmented sensory weighting. So those of you that haven't completed the balance modules, which we're going to start rolling those out, those of you that have know the terminology between reactive and anticipatory, and you can make a comment that they did it with this augmented sensory weighting. Another example would be patient's balance improved as evidenced by improved 5-time sit to stand and tug scores after targeted sensory weighting was used during treatment. There's no reason an assistant couldn't use a line like that, because that's just an intervention that they added while they were working on some balance. Patient's gait and balance positively impacted by targeted sensory weighting, evidenced by improved gait velocity and 6-minute walk test times. So you see how you can, in one line, say a lot. So I just threw those in there as some examples for all of you to use, hopefully helping you with what you might document. So what's the ordering process? I sent these documents out to all of the program managers in the facilities that were trained. So I'm just going to look at these real quick with you all again. Oops, how did that happen? So this is just a very simple thing. What you're going to do for these inpatient vests, you're going to fill out the order forms, which we'll show you in a second. You're going to scan those and email them to me, and then I'm going to approve them and send them on to purchasing. These are still blocked items so that people that have not received the training aren't going to all of a sudden go, oh, well, look at this. This is on DSSI. I think I'll order. This looks kind of cool. That's the process right now until the volume gets to a point where I can't deal with it. Then we'll go to step, phase 2. But that's not really an issue right now. I'm not seeing anything coming to my way. So that would be the process. And the cost of the vest is significantly less than it was before. The next thing, and again, I want to reiterate that I think it would behoove all of you to maybe try to get another vest or two into your rehab department so you have them. So this is the actual order form, which I sent out to all of you. You see that there's different sizes, so there's kind of generic sizes now. So if you look at the first line, they had to do it this way because that's just how they do their SKUs and all that. So if your patient with your measurements falls in these categories, then that's the one you would order. You see they're $150 as opposed to $300, or it was like $600 for the patient version. And then you see how on the bottom here we have if you needed an extra weight or two or quarter-pound weight, so that's how. You can get a whole weighted sensory kit, which is 8 half-pounders and 8 quarter-pounders, that's $200. So you all have that in your assessment kits already, but I think sometimes you might need some additional weights, so that's why I asked for individual weights. Also, the weights are now coming in a kind of a neoprene-ish kind of cover, not the one they have now, but one that's wipeable. Okay, so we can wipe them off. That was the other thing that they were working on. So they've really, really tried and listened to all of the input that we've given them, and I think that it's getting to a usable product, but I would really like to see us use more of them. So that's why we did this webinar, and that's why I'm encouraging all of you to communicate with the assistants, and let's start using more of these. And then right here, this is the final document, and if those of you, if either one of you do not have these, then just email me and I'll re-email them to you. And so these are just, again, the general sizes, as you can see. Similar document as the one I just showed you. All of you have my email, and if you need any other additional documentation, just let me know. All right, so what I'm going to do now, I'm going to go ahead and open it